Let's get right into this high-yield dermatology and wound care explainer. We are focusing purely on clinical decision-making for Step 2, covering pediatric vascular lesions, soft tissue infections, and wound management. Section 1. Pediatric lesions and mimics. Presentation and timing are exactly how you'll differentiate common pediatric dermatologic lesions on test day. You need to differentiate these 3 lesions for the exam. First, congenital dermal melanocytosis presents as gray-blue patches that eventually fade. Compare that to nevus simplex, which is a blanching pink patch, usually on the eyelids, glabella, or nape of the neck, and it also fades. Then there's nevus flammeus, the classic port wine stain. That one is a red-purple patch that respects the midline and does not regress over time. Looking closer at congenital dermal melanocytosis, the morphology is a distinct gray-blue macule. This is highly common in African, Asian, and Hispanic infants. You'll usually spot it on the sacrum or buttocks, and as we noted, it fades spontaneously during childhood. Now, here is a crucial step for management. You have to document congenital dermal melanocytosis clearly in the medical record, because it visually mimics traumatic bruising. Failing to note it early on can lead to misidentifying this benign lesion as a sign of coagulopathy or even child abuse later down the line. Section 2. Infantile hemangioma decision logic. Infantile hemangiomas present as bright red, soft, raised plaques, very often located on the face. Unlike congenital dermal melanosis or nevus flammeus, these do not show up immediately at birth. Instead, the timing is distinct. They appear days to weeks after birth. From 0 to 6 months, they go through a rapid proliferation and growth phase. Then, after 6 months, they enter a phase of involution and gradual regression. Because of this natural history, for most of these, the correct management is simply observation. But you need to know the specific clinical triggers that dictate when an infant needs advanced imaging or endoscopy. If there are 5 or more cutaneous lesions, trigger a liver ultrasound. For facial or segmental lesions, you evaluate for Pacey syndrome using an echocardiogram and a head MRI. If the lesion is in the cervical, facial, or beard distribution, that requires a laryngoscopy to check the airway. And lumbosacral lesions require a spinal ultrasound. For high-risk infantile hemangiomas, meaning those with airway obstruction, visual impairment, or hepatic involvement causing high-output heart failure, the first-line treatment is beta-blocker therapy. Specifically, propranolol promotes regression via local vasoconstriction. Section 3. Necrotizing fasciitis evaluation. The mechanism here is rapid spread through the subcutaneous tissue and deep fascia, which undermines the skin. For microbiology, the primary offending organisms include Group A Streptococcus, Staphylococcus aureus, Clostridium perfringens, or polymicrobial infections. The clinical clues usually start with minor trauma, often on an extremity or the perineum, followed by erythema, edema, and systemic toxicity like fever or hypotension. What you're really looking for is severe pain out of proportion to exam findings, paresthesia at the wound edge, dishwater drainage, crepitus, and subcutaneous gas. And remember, do not let normal-looking overlying skin delay care. Management requires an immediate 2-step approach. Step 1 is urgent surgical exploration and debridement. Step 2 is starting aggressive, broad-spectrum antibiotics, and the typical regimen for the exam is vancomycin, piperacillin tazobactam, and clindamycin. Section 4. Surgical site infection prevention. When assessing surgical site infections, break down the risk factors. Patient factors include malnutrition, obesity, glucocorticoid use, immunosuppression, smoking, uncontrolled diabetes, peripheral artery disease, and concurrent infection. Then you have procedural factors, like emergency surgery, operations for malignancy, open approaches, or inadequate prophylaxis. Finally, personnel factors, which primarily include inadequate hand hygiene. Prophylaxis depends on the wound class. For clean surgeries, like cardiac or orthopedic procedures, target skin flora using first-line cefazolin. For clean contaminated surgeries, such as gastrointestinal or head and neck procedures, you need broader site-based coverage tailored to the specific endogenous flora of the viscus entered. Section 5. Wound dehiscence clinical management. In superficial dehiscence, the separation involves the skin and subcutaneous tissue, but as you can visualize, the underlying rectus fascia remains entirely intact. The management logic here is straightforward. Superficial dehiscence presents with that intact fascia and maybe some scant serosanguineous drainage. You manage that conservatively with local wound care. Deep fascial dehiscence, on the other hand, involves true fascial separation and potential exposure of intra-abdominal organs. That is a surgical emergency requiring urgent operative repair.
Section 6. Ulcers and osteomyelitis. Check.
Pressure ulcers happen over pressure points in immobile patients. You prevent them via frequent repositioning, optimizing nutrition, and moisture control. Aphthous ulcers are a bit different, presenting as painful, shallow oral ulcers. If they are recurrent or severe, they strongly associate with systemic conditions like Behçet disease, inflammatory bowel disease, celiac disease, HIV, or neutropenia. Moving to diabetic plantar ulcers, these develop through a specific mechanism, a combination of sensory neuropathy, autonomic changes, and motor neuropathy that causes atrophy of intrinsic foot muscles. This atrophy leads to claw toes, hyperextension, and repetitive focal pressure over the metatarsal heads, which ultimately drives the skin breakdown. If you suspect osteomyelitis under a diabetic ulcer, follow these sequential diagnostic steps. Start immediately with the probe-to-bone test. Then, check inflammatory markers and get imaging. Finally, you confirm the diagnosis with a bone biopsy for histopathology and quantitative culture. Let's do a compact recap. Document gray-blue congenital dermal melanocytosis early to prevent misdiagnosis. Know the triggers for advanced imaging and infantile hemangiomas. Debride necrotizing fasciitis immediately. Match your surgical site infection prophylaxis to the wound class. Repair deep fascial dehiscence surgically. And biopsy deep diabetic ulcers to check for osteomyelitis.